So number one, I think and I like this country, and because I'm here a lot for many things, and I think this illustrates that was just taken yesterday with José Manuel, and he wanted me to learn more than academia. And for example, you can see that we don't drink the same thing. He's very sober. He's on a Perrier, and well, I went for the cerveza, and also the generosity. This paella was very good. I learned a lot about paella. I have even the right to give my opinion. And at the end, you even have a gift of the rice, so I try to reproduce that at home. That's already an academic exercise, a little bit. So since I've been so lucky to get this award, the Juan Calvo, I wanted to look a little bit. So that's a long time ago, right? It's 500 years ago. And we see a few things. Number one, when I'm reading it, I could see that at that time it was really someone who wanted to learn outside, right? So he's born, I think we're not sure where he's born exactly, but anyway, in the area, and he studied different things, humanities, medicine. He went to different places, Saragossa, not next door here, and Italy, and in France, and in fact published many things in French. And then he came back to Valencia to basically teach what he learned during his being outside. So I think it's an example even today, people going away and coming back and a broader view of medicine. And he teach really theoretical and practical lesson in surgery, and what Manuel just mentioned, Pierre from his home, so there was no limit in what he wanted to do, and I think from that he qualified as an international, in the 1600 here, academic surgeon, and he also went with the mentorship, right? That was not new at that time, but the mentorship, that means what you have, you communicate to others, which means there is an impact. There is a very strong impact, and in fact, not only the area, but it was printed for 300 years. Who of us would be printed for 300 years? I'm not sure that anything will last 300 years. When it lasts 10, 20 years, we're happy. And as was mentioned before, at that time, the big problem was the syphilis. It was a surgeon, but you also tried to cover everything that affect the society. So from this, it's really an academic surgeon, and it's certainly an honor for me to receive something that holds his name. Okay, so now I discuss with José Manuel what should I talk about, something very in detail, transplantation, and then went to this challenging topic, what is an academic surgeon? And successful is even more difficult, but what is it? How do we define that today? And I think this is a pretty good topic because it's not so clear. So what means success, or what means academic? What is it? Is the number of papers that you have? Citation, impact factor, whether you have another degree, a PhD degree, if you're the president of a society, then I'm sure it's important. Being famous, having a lot of money, or if in addition, the best quality of life while doing, what is it? I would not give you the answer, we just give the talk, but that's one of the heavy topic that we can have. And, sorry, yeah. So some of the slide doesn't work, but we'll do with that. So there is clearly no magic bullet, there is no formula, and there is no, and I'm happy about that, an algorithm, what means academic surgeon and successful in addition. So we'll just go a bit with, go to this. So the three topics that I think, but I will develop that a little bit with examples, is to be enthusiastic, what we call the fire in the belly. You want to do, you wake up in the morning, you want to change something. Opportunity, I mean, that's all of us. You have luck, you meet the right people, or you trust the right people, or you trust the wrong people, and that's an impact. And the mentorship. And we'll also develop a little bit that, how important it is, and that's applied not only to academic surgery, but many areas of leadership, or someone who can have an impact. So I also have what you learn. I mean, I have been in different systems, etc. What you learn, what you keep at the end, and can you that also communicate to other people? So I just show, that's an old cartoon that I had here. So you have here, this guy asked his dad, is the world round or flat? And the answer to that is, well, what that has to do with us? We don't care. That's not important, right? So that's the attitude of many people for that. And in fact, the first thing is curiosity. You don't accept things. You just think and you try to challenge that. I think that's the start of absolutely everything. And then I go back to this name. I mean, that's exactly, at that time, what he did. He traveled, he went other places, published in different languages, etc. So this is nothing new in this line. Now, when you want to know, when you want to go somewhere, the first things is the observation. You need to see things, right? And then to ask a question. That's the way. And then I really refer during the talk and very often to this 1966 Nobel Prize, Dr. Huggins, who worked, in fact, on the discovery that hormone can control some tumors. And what he had is really ask a simple question. And these people who are very bright, they don't go, it's very simple, that everybody can understand, and you try to come in the complex world of physiology, disease, to a simple answer. So I will refer a bit to what I have learned, what I've done. So I go back also a long time ago, when I was in Switzerland, like Dr. Calvo, I realized Switzerland is very small. Academia is very poor, and it was very poor. I mean, in number, they're not much, and I felt I have to go. I mean, I would not stay in Switzerland. Sorry. Yeah, thank you. So I wanted to not to stay in Switzerland, so I got the opportunity to go to Toronto to this surgeon, Steve Strasberg. That's those who work in transplantation know the name. And at that time, the topic, many years ago, in the 90s, the topic, how do we preserve organ? How do we do that? And one group in Wisconsin made a solution with many things inside, and it works. And then the question was how it works, why it works. And that was basically the PhD thesis that I had to do with Steve Strasberg. And the observation we had, that's a slide from a liver, and you can see, I don't know if I have here, I can point something, but you can see here. So that's the hepatocyte, and that's the endothelial cell, and they are very well attached. And now if we do cold preservation, just observe what happened. This endothelial cell detach. So that was an observation that we had at that time. And then the questions, this Huggins question is, why is that happening? What's the mechanism? If we want to reverse that, you need to understand somewhat the mechanism. And that was the PhD that I did in Toronto, develop a pretty simple, if you look like machine, that is for the lab, who basically were reperfusing rat liver for different time and then study a little bit all the mechanisms. I will not go in many detail. That was the first paper. We just show that the longer the preservation is, so more injury, more cell, what we see is the decrease of cell in the perfusate, so they are sticking in the endothelial cell. I will not go, but that was the first, an observation of some of the mechanisms that was going on at that time. Now, at the same time, when you involve not only in one area, but in others, that's exactly at that time that came laparoscopic cholecystectomy. In fact, I assisted Dr. Strasberg, who performed the first laparoscopic cholecystectomy in Canada at that time. It lasted 7 hours, so that was a pretty big operation. We prepared a lot. And then Steve Strasberg was a real academic, and then the questions was very clear. It was appealing. Patient wanted it. It was not developed in that area, but we did not know, is that safe to suddenly do this small hole and go? And there was a report published in the New England that suggested that with this operation, you have a lot of bile duct injury, so serious complications. So the question we have, is this safe? You know, can we do it? Is this safe? And then we realize, how do we do this? How do we know that? So there was certainly no randomized study possible. How do we do that? And then we were looking at the data. I was in Geneva, the data in Canada, from open cholecystectomy versus the new laparoscopic, and try to see. But what we realized, it's impossible to know complication in the literature. You had serious, severe, etc. We have no clue reading the paper how, except mortality, fortunately is very low with this procedure, but it was impossible, basically, to answer these questions. So we developed at that time the first classification. It was in 92, long time ago, while I was in the lab. So you have a lot of time in the lab because you wait for it, etc. And we developed a first classification that we could apply in the literature about morbidity and complication to be able to answer this question, is this laparoscopic cholecystectomy safe? I will come later on that, but that was just a mechanism to try to answer this question. Now, another factor that I have seen, not just for me, but with many others, and I like to cite also this Nobel Prize from 1937, around today, research is to see what everybody sees, and to think what nobody has ever thought before. So that's basically a very important attitude for research. So you need to think a little bit out of the box in that. So you need also a mentor that tolerates that you may have different idea, most of the time you're wrong, or you can be wrong, but it's nothing that is idiot, etc., to go outside of that. I give you another example. That's I will do example for when was that. We were very interested in the lab about liver regeneration. As you may know, liver is a unique organ. You cut 2/3, and in 2 weeks or whatever, it grow back. And still today, we don't have the exact mechanism, how this is happening. So in the lab, we did many work before, and we became very interested in platelet, just by observing in livers that platelet, they decrease dramatically. It seems to correlate with outcome. Was not clear, so that's some of the observation that we had, and I wanted basically to look at whether platelet, well, that's the hypothesis, work in regeneration. So what about platelet and liver regeneration with whatever we have observed before? And I asked a fellow, French fellow from Paris, now he's the head of surgery in Hôpital Beaujon in Paris, but at that time he was a young surgeon who wanted to go outside of France and learn. And he ended up in the lab. He had also a fellowship from the International Hepatobiliary Association, and he came in the lab. I was not very nice with Michael Lezurtel because I asked him this pretty difficult question, does platelet works on this? So he started in the lab, so you need first to develop a rat or mice, both that have low platelet as a model, and then you go to what everybody knows. If you do an hepatectomy, you cut 2/3 of the liver. That's KY67, that means mitosis. You do that, and very quickly, this liver explodes and has mitosis. So that's what everybody knows. First, you need to have this. Then you have to do in a rat that has no platelet. And what happens when you have no platelet? It bleed, right? So the poor Michael worked on the model. I mean, that's absolutely what happened. He came in my office, and he said, I'm leaving. I cannot stay here. I mean, it doesn't work. I mean, what do we do? I mean, I have done all this hepatectomy. They die on the table. I mean, they bleed and they die on the table. So that was a little bit embarrassing. We have a long conversation, try to motivate that. And I think that's the one, maybe the citation that I like the most. Our greatest weakness lies in giving up. The most certain way to succeed is always to try just one more time. Einstein has several of these same studies. He said he failed 99 times and 1 time he was right. But that's a bit of everybody who goes in the lab. That's not for easy thing. You need to persist and to persist. It's easy to say. So I would make it short. So he did it. So after that, he did it. He had an antibody. I mean, I would not go into detail. And then first observation, that was a great day that day, because when he took the platelet away, the liver did not regenerate. So that was the first observation. Maybe it's important. Okay, that's a very surgical stuff. Then I would just go a little bit in physiology here, but there was the help of other people. We started to think what is in platelet, what can be involved, and for many discussions, we thought it could be serotonin, which increase mitosis, and serotonin is in the platelet. 99% of serotonin in the periphery, not in the brain, is in platelet. So now there was a scientist, nothing to do with us, in neuroscience, from Berlin, who studied a lot serotonin in other disease, and basically the way it works, the serotonin comes from L-tryptophan, an amino acid. I learned that also at that time. And in the gut, in the duodenum, in fact, in the mucosa, there is this TPH1, tryptophan hydrolysis 1, who convert this to serotonin, and then it's taken by platelet. So from this, what we did, that's the wild type, so the normal mice. And then we have, now go here, then this was a physiologist from Berlin, have developed a model where you can remove TPH1, so a knockout mice, which means that. So you have normal platelet, but you just don't have serotonin in the platelet. Easy to understand. So that was what we did, and when we did that, bingo, no regeneration. So that was very interesting. And then when really it became very interesting and convincing is that you can bypass that. If you bypass the mice who miss this enzyme, so doesn't produce, you give a substrate, HTP, and it will produce the serotonin. So when we did that, bingo, the liver regenerate. So that was a very, very interesting observation, pretty novel, and in fact, he ended up for Michael Lezurtel in a paper that we don't have very often as a surgeon in Science. So we sent to Science, they found very interesting, and they published that, and that basically, he did more than that, but helped him a lot in his career. He was the first surgeon in France, active surgeon in training with a paper in Science, and this observation was also important because Very often we find something, but nobody can reproduce it. That's not very convincing. So this work that Michael Resutel has done, many other people in the lab could work on that, even the cover page on PNAS by others. So basically, it was a true finding that serotonin mediates that. So very importantly, it has an impact on people. They got also some metric on this. But the test of time and impact of others give the real value to our work. I think that's very important. We're very happy to do, but others take it. Sometimes it takes time. It takes years until people can do it. But that was another thing. Now I come back to the classification. So we were lab chole, open cholecystectomy. We got a paper in the journal Surgery. As a very young fellow, was very happy with that. And with our classification, we thought it was very good, but nobody used it. Right? So in 2000, so in about 10 years or 7 years, nobody used this classification in the literature. So it was a wrong idea. Should we give up? Same question and go back. Well, we did not. In fact, when I arrived in Zurich, there was a young resident, Daniel Dindo. We say something is wrong, let's reevaluate. So we did a survey with why it does not. And the reason it did not work, it was many subjective things. Some has a hospital stay twice the normal hospital stay, etc. So that's very difficult to understand. So like the idea from Huggins, let's stay simple and something we can do. So basically, in order to prevent people to go around that, you have a complication. What you need to treat the complication will grade the value of your complication. That was the principle of this that Daniel Dindo published in 2000. And that's, I will not go to this, but that's fine. It's relatively easy to understand. And you go to the end, it's death, the beginning is minor. And every time it's related to something. And that's now used by AI. It's not that I want to vote for AI, but the AI can go in any charts if it has access, and it can go immediately to the, it cannot. I mean, if you give antibiotic to a pneumonia, that's what it is. Patient go in the intensive care unit, it is. So basically, this thing, which is supposed to be simple and transparent, could be useful, has been well cited. Sorry, I give a lot of citations here, but here I go to a French, Victor Hugo. I think it applies. Nothing is stronger than an idea for which the time has come. Many of us and many here, you have idea, and then 10 years later it becomes the hot topic. But I had the idea 10 years ago, right? But nothing happened. It's not the time. There is a time when something can happen. If you're too early, the history is plenty of stuff like that, never happened. And you need to be a little bit out of the box and to do when the time is correct. So I come back quickly to this classification. So people use it. They could grade the complication, but we have a problem with this. You have two patients here, for example, who have different grade of complication. I mean, a big procedure, you don't have one, but you have 3, 4, 5, 6 complications. Which one of these has the most serious morbidity? That's the question. Which one? I can tell you, it's very impossible to say what that is. So that became a very important question. We did not know how. And then that's the question. Can we create a simple metric covering whole morbidity? I mean, it's easy for mortality, 2%, 5%, everybody understand, but morbidity. Can we have a metric that we can apply for that? And I was, at that time, that's 2009, I was part as a surgeon of a relatively small group in the Oxford. We met 3 years in a row to address. It was also Monday. How do we evaluate new machine, new device? And we met. There was mostly statistician here. Jonathan Mickens was the previous head of surgery at McGill in Canada. He was the chair of this. And we met. There were surgeons and all these very smart statisticians for the Oxford evidence-based. So it was a very good learning stuff. And I took advantage also, and they published these 3 papers in the Lancet on 3 years. So how do we evaluate innovation? It was a very nice stuff that had an impact later. And I took advantage and I asked a question to the group. I said, I have this problem. I want to have morbidity. Can we do it? And the conclusion from the very smart statistician and all that, they said, how do you do this? No, we cannot. It's not possible. Well, we did it anyway a little bit later. And that's Xenia who did this PhD on that topic. And basically, I will come how it happened. It was an advantage to be in Switzerland, because in Switzerland, the economy is very important, right? People invest. Why you want the money to come in Switzerland? How you invest. So you need to give an index to the people who want to put their money. And the index is stability of the government, stability of the money, whatever. So they put the parameter you want, and then you come with an index. that tell you what is good in a country. They apply everywhere to have this. So we say, well, why not we can apply this kind of stuff in medicine and try to do it. What we have this classification, and we wanted to have also patient perspective in all to that. And she did the work. So first of all, went to the economist. We found a few, tried to understand how they do this. And basically, this is called Operation Risk Index that everybody in the economy used when they want to place their money. And that's risk analysis. We apply that with the grading system, how we can do that. And that's Milo Puan. That's also when you do research, you're very lucky sometimes to have right people. He's the head of epidemiology in Zurich, and is really the mathematician behind that. So we say we want an index, which we call complication comprehensive index. What I want is 0, no complication, 100 deaths. And then we put in the middle all complication, and you give us an index. And that's the formula. So she did a PhD. So basically, she did vignette, she did the scenario she gave to patients, doctor, nurses, and they have just to grade how serious it is. And then with this information, they get this formula. You don't need to have that, but that was the formula that was done to develop the CCI, which now is calculated automatically. Go back to this patient. CCI, first one is 31, the other one is 44. So here we have now, if we believe the data, a very simple way. You just plug the complication on your system, and it will calculate and give you what this index of morbidity is. And in addition, from that, you can grade that over time. You know, for time the patient get the hospital, they say long time, 1 year, and you can really, you just add that to your computer system and increase the CCI. 100, you cannot go above that, you are dead, and 0, you have no complication. Now, like any good discovery, there is maybe a side effect. The side effect, I don't know if it's good or bad, is a good friend, Dr. Yang from Seoul, is probably the most active gastric surgeon in the world, who used this classification to label his surgeon. So he has 6 surgeons, and he was calculating the CCI, and the poor guy, if they're surgeon B, then he will ask him to come and discuss what's going on, why you are not as good as the other one. So that's just an example how this can be used, and I know that he's still using that today. Now, the thing that, okay, that's fine. The next problem is that, okay, you have the CCI, wonderful, but what it means. So there was a number of randomized trials using these markers. You have a difference of 2 points, 3 points. Is that relevant? Does that mean anything? So that was one of the questions that we were asking, and that the last work that was presented last year at the European Surgical Association. But before I show you an example of data that we are so many of these data, many examples. Murray Brennan is a surgeon from Mount Memorial, has done now many talk about how stupid our data in the literature. You can do it. So an example. So this is a paper who basically evaluates 2 chemotherapy in pancreatic cancer. Randomized controlled trial and published in a top journal, Journal of Clinical Oncology. It's a good journal. What's the data? So a lot of patients with non-operable pancreatic cancer. They're randomized, looks pretty good in the method, and they have a statistical significance of 0.4. That's what we like. So they came with this, so they said, okay, significant. Looks pretty good, very good for the pharmaceutical company, but what it means, the difference was a survival of 6.2 versus 5.9 months with chemotherapy and toxicity. So the questions, is this 10-day difference really make a difference? What it is, and the literature is full of these p-values that are just given without. So that was Fariba, which a fellow now just completed a PhD also, and she did that on this very important, and that's what I teach to the resident, maybe the only thing they need to remember some of the talk is this minimal important difference for patients. When it matters for patients, because what we do is for patients. We don't do for us or for statistics, we do for patients, so how do we evaluate if that has an impact for patients? And I would make it short because for the time, so they did a study. She took 3 randomized trials that were done in the Netherlands, in Sweden, went back to the data. They have all this CCI, this index, and they have other factor of quality of life, patient-related outcome measure. She correlated everything, did all that, and at the end, and that's the message, is that in order to be relevant for the patient, this clinic minimal important difference is 12 points. So now what we suggest, you may need a p-value, but if you don't have 12 points difference, Your data is irrelevant for the patient. It will not change anything for them. Okay, now just another example. I just took a bit. Does research matter for the clinical mission? I mean, I have a lot of this question. Why you waste your time in the lab doing this rat stuff? I mean, somebody can do it, and is that really useful? And I think that's a very important question today to convince residents or young people to engage, some of them, to an academic career, meaning doing some research. Does that matter for the hospital? The hospital now, they don't have money. You take people away from the clinical duties. So is that really bad for the hospital? And I want to give an example here that, in fact, it's probably not bad. And I go back, so we do research. They don't like us because we need space, we need money, we take sometimes the best people in the lab, so why they should be interested. So I go back to the example of the paper from Michael Zürtel. It was good for him. He went many places in France. He did also very good other work, and now he's one of the most prominent chair in France at the Hospital Beaujon in Paris. Good for him. There's no questions. It's good for him. But now if we go here, it promotes the team. You have seen many papers, many other fellows could test the serotonin in other disease, in cancer, etc. But there's still no benefit from the hospital, absolutely nothing. But this similar focus, so it helped getting patients. People start to know about us, start to know we do research, we're very interested in liver regeneration, and it attracts some patients, both transplant and others. So that started to be a benefit. Then came the New England. They were like, and they said, can you write a review article about liver surgery in general? It was not bad. The New England is not bad to have a paper. So that was just after this. So we wrote a very general article about safety for liver surgery, and that was the area of small for size, that if you take too much liver, patient have liver failure, etc. That was very good. And then what happened? Well, a paper in the New England, they read it, they know it. So suddenly the hospital, that's very surprising. In Zurich, the New England invite you to write. That's interesting. Patients go on the internet. So it increased complexity. It attracts young collaborator that has extreme value, because what I do is really worth not much. But if you attract the top ambitious or young people that come from many countries, that's what promotes your things, and it brings money to the hospital. So it's not obvious from the first thing, but if you can go to that, it's an example that a hospital or academic will benefit from that. Okay, so that I think is another one. This one we give course in our ward, and that's not something that many people believe, but I think it's very sustained success. So long-term success of academic medical center depends exclusively, only on outstanding research. And when you talk to our CEO, they say, okay, yeah, the talk, I mean, who cares? I mean, this is, you just speak for you. But that's really what need to go if you're an hospital. And that's something we have to learn from the US. I think we're progressing. Europe, we are not in the same spirit that they are in the US. They have other problems in the US, and now they're going down. So we have also an opportunity to take over. Now, I think that one of the last topics I want is that can we, an example, compare result of surgery among centers? That's a hot topic also, Is Alicante better than Valencia? Is Zurich better than Geneva? And how do we do that? What that means in terms of this for different procedure? And we came with one of the concept of benchmarking. So we have this center. So that's a Swiss picture, as you can imagine. So here, this is center 1, center B, center 3, and that's the outcome. Whatever we measure is automatically center 3 worse than center 1. Probably not. They may not have the same patients. So how do we do to compare this? And it became with an important topic now of benchmarking. How do we set one tool is not the only one, because there's a lot of statistic, multivariate, nobody understands the methodology, and it's abused. That particularly in the US to show that center A is much better than the other one, etc. And the data is totally biased, very often biased. Could we help from our perspective in this? So we decided, to show an example here, we decided to develop a novel methodology with many other groups about benchmarking. Here is one of, I think several of you knows her. She knows her. She's now in Barcelona. She was a fellow for 3 years with some, Patricia Sanchez Velasquez, and she did the fellowship, and in between did one of the first benchmarking on pancreatic surgery. I will not go in detail, just show you a few slides. It's a lot of work, so you want to have benchmarking, so you need several centers. You cannot say, I am the benchmark. And then that was the center involved, so she contacted this center to get the data. You can see fair number in Europe, In the US, the Baltimore Johns Hopkins, MGH, Mayo, etc. were here, and some centers in Asia. So you need to convince these people to give us the data. And then the question was Whipple, that was open, that's useful because now we just did the robotic. We wanted also a good definition, resectable lesion. We don't want to have locally advanced tumor, no previous surgery. So the good case. So we wanted to see in the good case what are the best results you can have in expert centers. Center have to be expert with a minimal number of cases. So that's just the data from 6,400 Whipple. There was about a third who were benchmarked, so-called easy case or with low-risk cases. That's the data. She analyzed that. I will not go for the methodology. But at the end, I say, OK, the hours for benchmark should be less than 7.5 hours. There was no transfusion in this patient as a median. The ICU 1 day, et cetera. So came with whatever you want to use as a benchmark, which is what you achieve with good case in center with a lot of experience. Then you can go to many things. And for example, here, the fistula, and you can see this is 20%. It's not zero. That's the benchmark that you can have with this group. Now, I just showed that because it was a very interesting observation. We go further step. That's basically the 23 centers on the bottom. And then you have in blue, in gray is all the case, and in blue is the benchmark case. So in blue, show the easy case. And the other one show the case that were more complicated. And then we're interested, 2 centers, same volume, these 2 centers. And you can see that the center 13, they have very few good cases. They operate high risk. And the other one has almost exclusively easy case. So what that means? And we observe, in fact, that the one who do a lot of difficult case in this easy case, it basically no fistula, while the other one has more fistula. So if you operate only on easy case, you're probably not as competent as doing difficult case, and you have more problems. And that's not easy to demonstrate, but that's an interesting observation. So clearly, the center experience in difficult case play a role. And then we had another observation, very interesting. So the benefit to treat difficult case. That's a very big message in the US. They don't like to operate difficult case. They have lawyers, they cost a lot of money, so they are much less aggressive than we are, and I've been both sides, that we are in Europe in general. Same thing in transplant. We accept very difficult high-risk organ, they don't. And that's a different culture in some way. And here is the Johns Hopkins, I mean, they agree with you, that's the largest program. And you can see they operate also, they refer the case that nobody wants. So in the US, they operate almost exclusively non-benchmark cases, I mean difficult case, and the fistula is higher, is in between, and then it came to the concept of breakdown. So if I summarize this, work on by René Forlanten, that's what you have in terms of outcome. Whatever you want to check, mortality or CCI, you have the volume in the ball, so you do very few, you have poor outcome. I think everybody agree with that. If you do 2 Whipple every 2 years, probably that would not be good. And then you have a learning curve, whatever the number is. Then you have a plateau. When you reach enough, then you have the best outcome you can have. And then after that, you have this breaking point that's been observed in different centers. You do too many. And you do too many, you don't have the surgeon, you don't have the same attention, you don't have, et cetera, and the quality go down. So obviously, there is also a risk by too high volume centers. So that's, again, a bit common sense in too large centers. And I have another one, I will not go in detail, was done by Clavien Müller. He was from Luxembourg with us. And he did one, same, you can do any procedure you want to do. That was done on liver transplant here. I will not go in many detail. The volume, we want at least 50 liver transplant per year to qualify. And then we did the benchmark. Just this graph as an illustration. You also have something new here, because with the CCI, you can see that the CCI increase over 1 year. And how long do you follow a patient to make sure that you cover all the problem? And liver transplant is an example. You can see between 6 months and 12 months, the CCI, the morbidity increase. Then you have a plateau. Conclusion we have here is that the minimum follow-up is 1 year. That's what we say. If you really want to report your transplant, you need to follow all your patients for 1 year. Liver surgery is 3 months after pancreas is 6 months. So we could learn for any procedure how long suggests we should follow the patient. That was the benchmark value that we have for these benchmark liver transplant cases. Now, Yeah, okay. I mean, I put that. You stop me whatever you want me to stop because. Okay. Okay. So another questions. We go back to a simple question. So if we convince that being a scientist, surgeon, or whatever we want to call, how do we do that? How is that possible to go through that? And that's also another thing. Sorry for all this citation, but that's another one here. Extraordinary achievement is less about talent than about opportunity and work. And that's absolutely true. Obviously, I have so many bright residents who thought this guy a Nobel Prize, and they quit and they have, etc. And you have other one that says a bit slow learner, and then they develop them very well. They have the right mentorship, or they work more, whatever the thing, but it's not just talent, for sure not. And I wanted, I did not know I put that slide. But anyway, I want just to talk about, for me, just to show a bit that it happened. I was looked back many years ago. The very well-known chair, you probably don't know him in Switzerland, was Martin Algever. He was one of the big guy, the 5 big guy in the world of surgery, general surgery at that time. And I was a student at that time and wanted to do surgery and wanted to go to Basel. He was in Basel, but he was like the Pope or whatever for me. I mean, it was really. And I applied, I remember no in detail. And at the end, as a resident, they were interviewing, it's different today, they were interviewing 100 applicants, mostly for Germany, and they took one. So I thought, well, I did not speak German very well. And whatever, I got the job offer, exactly told me 3 weeks later, we give you an answer. I got it, it was very serious. They secured the board of surgery. So that was the opportunity to be selected as a young resident, knowing that this is not the end, you have to work to have this. Then I went back to him later. I was starting to do some study on CT and acute pancreatitis at that time. I asked him, and then I have a first mentor who, number one, looked at that, he had other things to do, and was very critical. And I would not go. You know, he was polite, I was in German, but basically to tell me, like, what you're doing now would have absolutely no chance to go. And it did help at that time, and that was the first paper I ever published about CT on acute pancreatitis. And not only I was happy to have that, but I learned a lot by this mentorship. And then, you know, he helped me to go to the US. When you're a small surgeon or small surgeon, you have no connection. That was my case. And I wanted to go somewhere. Quit Switzerland, you need someone who help you. And he did help that. I contacted him. He had a very large network. He sent me, as took 2 months, to visit different hospitals from Boston, etc. And at the end, I was lucky to got a job in Toronto when I did after that the PhD and the training in these things. And then I have 2 other absolutely key mentors. The first one I show Steve Strasberg from Mount Sinai in Toronto, where I did the lab, and then I did a clinical fellowship with Bernie Langer, which was of the big name in liver surgery, one the only center with Pittsburgh who were doing liver transplant at that time. And then coming back, you know, that's just to show you a bit of career. So I was in Toronto, pretty young, too young, finished my PhD. They trained me a little bit in liver surgery, and that's my boss in Geneva, where I was a resident. And that was mid-93, long time ago, but that's what the message. He told me, the plan was to go back. He promised me a position. The situation in Geneva is difficult, and considering your young age, today if you do that, you may go to jail in the US because you cannot discriminate. It is difficult to offer you a staff position as there are 4 people much older than you for advancement. So basically, you may come back, but nothing will happen for you if you go back to Geneva. That was not a good day because I was a Swiss, from Geneva, spent 5 years in Toronto. What should I do? I had a baby in Toronto. My wife was also Swiss. So we said, what do we do? And what I've learned, door may open, right? So you close one, you can open another one. And I was very lucky with Bernie Langer. They needed someone to develop liver transplant at Duke University in the US. I've never been, I did not know where that was. And then I spent the next 7 years in an American system, so I have to learn how it works, competitive, grants. I developed at a very young age the liver transplant program. It's not easy. I was the only one doing harvesting, implantation, and all that stuff. Well, you have to go through that, and then I could have some fellow. That's the first living donor that we did at Duke, with the mother giving to the daughter, and we continue to do some lab on this perfusion. I have someone from India, China, and we did not, it was not an incredible discovery we did, but we continue to do some research on. No, maybe that's, I hope that's my last. I go to Warren Buffett, who is someone who certainly has a vision. And I think this is, if you sit in the shade, it is because somebody else has planted a tree a long time ago. And I think that's exactly something that we see. Whatever we do, someone has done it before. And then it comes to a very important concept of mentorship. When I ask what's common in all these pictures, that in surgery or whatever, what it is, I will not, that's the mentor. There's always someone. If the mentor is not good, it's not good. But if the mentor is really here for advancement, out of the box and support, that's basically the only thing, or it's very difficult to do to succeed without this. So the notion of mentorship is here. And that was Bernie Langer. I thought he's an expert. He's a man who had made all the mistake which can be made in a very narrow field. So he admit what he has done. He was the most, or one of the two most prominent liver surgeons, and tell, well, if I can teach you today because I did a mistake before, and I would like you not to do the same mistake, basically. And of course, you just have to thank him for this attitude. And that's the last citation from a right civic activist from South Africa. I have learned that people will forget what you say, people will forget what you did, but they will never forget what you made them feel. And I think that's, sorry, that's very important also to have an attitude, a positive attitude, what we can go into that. That's my colleague from the head of orthopedic in Zurich, Christian Gerber, who also have this citation but that's very, he say, well, I don't believe you can transfer science. I hope you can a little bit, but you can transfer enthusiasm, which was it. So emotion and emotion IQ is central to the transmission of knowledge, no doubt. I mean, that's many examples that if you don't have that, you don't succeed. So I just summarize here the people you meet that make a lot of things for you, motivation, I mean, a role model and what they can do. The bottom is, that's Henri Bismuth. I never worked with him, but we're very close. And when I came back to Europe, rather than to see me as an enemy, etc., I mean, he really helped me. I mean, we became very good friends. So, and John Cameron from Johns Hopkins, we also never worked with him. I met him a few times. And we could do a lot of things with that. So that's the people for me that I own a lot personally, but could be that's very. So that's also another citation. Whatever you do, somebody helps you. And that's the other thing very important is the team. So it's an example of the team. That's what today I'm probably the most important for me is the people I have trained. And also we have 23 nationalities. Not always easy. If you put someone from China and India in the same lab, you have a good chance they will fight. That's the way they do. And I have some very dramatic stories. So that doesn't mean it's the easy way. But that's really the way to move forward to it. So that's a big satisfaction to, and when I went last year to visit Patricia in Barcelona, a fellow, I mean, I was very happy to do that. And above all is our patients. That's also another, it's a long time story. That's this young lady from Kosovo, this young girl who had sarcoma in the pancreas that was never operated. We decided to go, and it did work. So that's some of the very important things that you may remember. So at the end, if Jose Manuel let me, I will speak a little bit about the European surgicals. This is another topic, something that we have developed now with the European Surgical Association. So this is basically an online, I don't know if you're aware of it, but that's an online way of curriculum in surgery, which is normal for residents, but many young academic, or me, when I'm not in the topic, can go, is a formatted video. It's the same thing that you can go, and we have the chance to have, I think I've found 2 videos. I think you have more and more. Yeah. So we have these 2 videos that were done, and that's, I think, very good for the people who can listen it. It's very good also for Spain, because we want for international that, and that was a format, so a younger resident present, prepare well. There is an expert who supervise that, do the discussion at the end, and now, very new, what we have, and that's also, I wanted to give that, to give some credit to the Alicante team and others about outcome research. That's where we interact a lot together on outcome. It's a participate to many of the study, and that's just the number of publications that they've been done from this group. So what you tell about me, I want to tell the same about you. And he also participated, I put that in the consensus conference. So we've organized consensus conference with different people on important topic that was the quality of surgery. When we presented the CCI and other metric were covered, and that was published in Nature Medicine. And another one that was just last year, where I participate in a panel on cholangiocarcinoma. And I go back, I mix the slide with, I go back, that's the European School of Surgery. That if you can go here, you can have access. It's free. So one of the things we want with free education, which means many people in Africa, everywhere, they can look at this. That's very important. And now, very importantly, we have the UMS. So we accredited with the UMS. They found that very good, this school, and they will give CME credit. So people who go and watch this can get CME credit, which give with the European Surgical, which is the academic society in Europe, plus the UMS, it gives some credibility to this European School of Surgery. And as I say, it's open for anybody who would like to participate. Here, and Professor Hamia is already in the line with a few other topics, and we will have more from Spain. And now the last one that will come very soon, we are organizing a hot topic in our field is colorectal liver met. There are now even liver transplant that we do for this, for which patient, how, all this diagnostic, this cDNA, etc. So we decided in collaboration with the head from the surgery at MD Anderson, we co-organize a consensus conference soon, in fact, in a month. We have 8 panels looking at different topics, and Jose Manuel is one of the panel. I think one of the most important is the surgical one. I mean, what surgery? And today, do you do ALPS? What do you do? Do you transplant? So we have a consensus because there was no level 1 evidence. So you need to take everything that's available. And at the end, there's an independent jury. The president of the jury is the gastroenterologist from Mayo Clinic, Greg Goes, and the jury that listen to the expert make the statement at the end. So we take the bias of us, because we do, away. Is an independent jury that have nothing to do with liver surgery or colorectal liver met in the jury, which include oncologists, surgeons from the world of economy, and of course, patients. Thank you very much.